A 7-year-old comes to your clinic. Twice now, the parents have found him at night, one side of his face twitching, drooling, unable to speak but fully aware. By morning, he is completely normal. Is this something to worry about for life or something he'll simply grow out of? The answer depends on one thing, naming the syndrome. Because the moment you can say this is self-limited epilepsy with centrotemporal spikes, you can tell the family that seizures will almost certainly stop by puberty, or you can avoid a pile of unnecessary tests. Today, we are working through the 2022 ILAE position paper on epilepsy syndromes that begin in childhood, the 2 to 12-year age group. I'm Dr. Aditi Koimawala, and this is Nurture and Neurology. Let's get into it. Here's the map for the next 20 minutes. Under the 2017 ILAE classification, a syndrome sits at the third tier of diagnosis, and a childhood onset syndrome always comes as a package, a mandatory seizure type or types, an interictal EEG signature, a typical age window, and a prognosis. Get those four and you have a diagnosis. The childhood syndromes sort into 3 families, and that's how we'll move through them. Self-limited focal epilepsies first, then genetic generalized, then the developmental and epileptic encephalopathies. Before the individual syndromes, hold on to the shape of these 3 groups. Family 1, self-limited focal epilepsies, presumed genetic, normal cognition and exam, remission by puberty, classic semiology plus a specific EEG trait. These alone are up to a quarter of all pediatric epilepsy. Prognosis is excellent. Family 2 is genetic generalized, complex polygenic inheritance. Here cognition and drug response are variable. Some children do beautifully, others struggle. Family 3, the developmental and epileptic encephalopathies. This is where the epileptic activity itself drags down development over and above whatever caused it. Prognosis is often poor and the treatment approach is very different. Now a nomenclature note that trips people up. The word benign and idiopathic have been retired for these syndromes. Benign was misleading. Many of these children carry real cognitive and behavioral comorbidities. So benign Rolandic epilepsy is now SeLEAS. Peniatopolis is SeLEAS. Doose is EMAtS. Jeavons is EEM. The old CSWS and ESES and Nandokelefner are live under the SWAS umbrella. The new names describe the seizure semiology or the defining feature. I'll use both the new and the old names so nobody gets lost. One more tool before the syndromes. For each one, the task force gives you 3 lists. Mandatory features must be present. Exclusionary features must be absent. They rule the syndrome out. And alerts, rare but possible findings that should make you pause and look for a mimic. And usually, for many of us, in resource-limited settings, several of these can be diagnosed on clinical grounds or with a single interictal EEG. Though a sleep EEG is mandatory for HGS and SWAS syndrome, and MRI is required for COVE, POL, FIRES and HHE. Family 1, self-limited focal epilepsies, the ones we used to call benign. These 4 syndromes share a fingerprint, 9 features on the left of your screen, age-dependent onset, no structural lesions, normal development and exam, remission by puberty, a genetic EEG trait, classic focal semiology and a distinctive epileptiform EEG on a normal background. This schematic from the paper lays them out by age at onset. 2 of them, SeLEAS and SeLEAS, remit in every case. The other 2, COVE and POL, remission is highly likely but a few will persist. Start with the commonest, SeLEAS, self-limited epilepsy with centrotemporal spikes, formerly benign Rolandic. Onset 4 to 10 years, peak around 7. It's the most frequent self-limited focal epilepsy, 6 to 7% of all childhood epilepsy. The mandatory seizures are those unmistakable opercular events, dysarthria, the drooling, one-sided mouth twitching, and crucially 80 to 90% happen in sleep. Within an hour of falling asleep or in a couple of hours before waking, the EEG shows high amplitude centrotemporal sharp and slow complexes that light up in drowsiness and sleep. Remission by mid to late adolescence, no regression. The one thing to watch, a GRIN2A variant can rarely push SeLEAS into EE-SWAS with language regression. If a child with Rolandic epilepsy starts losing skills, that's your cue. Let's look at that EEG. Panel A, awake, high amplitude spike and wave over the right side centrotemporal lesion. Panel B, sleep, the abnormalities multiply and grow. Panel C, the periictal trace, and the semiology on the left is worth memorizing. Unilateral tongue and lip tingling, one-sided facial twitching, speech arrest with preserved understanding, and sialoria. What you should not see, and these are exclusionary, are generalized tonic-clonic seizures while awake, atypical absences or gustatory and fear phenomenon. Next, SeLEAS, self-limited epilepsy with autonomic seizures, the old Panayotopoulos syndrome, younger 3 to 6 years in 70%. The hallmark is a focal autonomic seizure and the dominant symptom is vomiting. In about 3/4 of children, often with pallor, retching and miserable unwell look, which is exactly why these kids get mislabeled as gastroenteritis. 2 facts to lock in. First, more than 70% of seizures come from sleep and they can be long, over 30 minutes. In fact, SeLEAS is the commonest cause of afebrile non-convulsive status epilepticus in children. Second, it remits within 1 to 2 years and about 20% evolve into another self-limited focal epilepsy, usually SeLEAS. Now the two occipital syndromes, COVE, that is childhood occipital visual epilepsy, formerly late onset gasto-type. Onset 8 to 9 years. The mandatory seizure is a focal sensory visual seizure from wakefulness. Small multicolored circles in the peripheral vision drifting across the field, often followed in about half of kids by a migrainous headache. Remission about 50 to 80% by puberty. And note, for COVE, MRI is required to exclude a structural lesion or occipital calcification. Its cousin pole, photosensitive occipital lobe epilepsy. The defining word is photic. Flickering sunlight, video games, screens, these trigger the visual seizures with head and eye version as the child follows the phenomenon. Strong female predominance and a broad age range. Mean around 11. Prognosis is generally variable here, with well-described overlap with the generalized epilepsies. One alert, a photoparoxysmal response at a slow 1 to 2 Hz frequency isn't pole. That suggests CLN2 disease. Low frequency photic testing matters. 4 syndromes, side by side. If you take nothing else from this section, SeLEAS and SeLEAS remit in all cases. You can stop treatment after adolescence. COVE and pole, remission is likely but not guaranteed. And the seizure type tells you the syndrome, opercular, autonomic, spontaneous visual or photic visual. Family 2, the genetic generalized epilepsies of childhood. Essentially, all of these are genetic with complex polygenic inheritance and a frequent family history. The big one, childhood absence epilepsy, is covered in a separate IGE paper. So today we focus on 2 distinctive childhood syndromes, epilepsy with eyelid myoclonia and epilepsy with myoclonic absence. One quirk worth remembering, EMATS, Doose syndrome, is generalized in its biology, but the paper classifies it under the encephalopathies because of the regression these children can show. We'll meet it in part 3. EEM, epilepsy with eyelid myoclonia, formerly Jeavons. peak 6 to 8 years, and the striking 2 to 1 female predominance. The mandatory feature is the triad rapid eyelid myoclonia, 3 to 6 Hz jerks with the eyeballs rolling up and the head extending, with or without absences, induced by eye closure and light, and most prominent on waking. On the ictal trace, eye closure triggers that generalized polyspike and wave. It's often drug resistant and frequently lifelong. There is a photosensitive subgroup, the old sunflower syndrome, who self-induce by waving a hand at the sun. EMA, epilepsy with myoclonic absence, formerly Boro and Tassinari. Peak around 7, males about 70%. The seizure is unmistakable once you've seen it. An absence with rhythmic 3 Hz jerks of the arms superimposed on a tonic abduction. The arms ratchet upwards. And on the EEG-EMG here, that 3 Hz spike and wave is time locked to the jerks. Prognosis is more guarded than the self-limited group. Remission is only about 40% and intellectual disability ultimately in around 70%. Family 3, the developmental and epileptic encephalopathies, the most serious group and the one where naming the syndrome changes everything. First, the vocabulary, because it's precise. An epileptic encephalopathy means the epileptic activity itself is degrading cognition beyond the underlying cause. A developmental encephalopathy is impairment from the underlying cause without the epileptic drive. And a DEE, developmental and epileptic, is when both are true, which is common because so many of these gene variants impair the brain in their own right. Why fuss over the words? Because they tell you how aggressively to treat, how to counsel the family, and whether a precision therapy is on the table. EMATS, epilepsy with myoclonic atonic seizures, formerly Doose. Onset 2 to 6 years, and here's the hopeful part. Development is normal in 2/3 before onset. The mandatory seizure is the myoclonic atonic, a brief jerk followed by a drop. There's often a stormy phase with regression that improves when seizures are controlled, and 2/3 achieve remission. First alert, tonic seizures within 12 months should make you think LGS instead. Second, about 5% have GLUT1 deficiency from an SLC 2A1 variant, and GLUT1 is treatable with the ketogenic diet. That's a diagnosis you don't want to miss. Lennox-Gastaut syndrome. And note, the name is deliberately kept. Onset 18 months to 8 years. Peak 3 to 5. The mandatory feature is a triad, tonic seizures obligatory, plus at least one other type from a list including atypical absence, atonic, myoclonic, focal or epileptic spasms, plus cognitive impairment. About 20% evolve from infantile spasms, and intellectual disability eventually affect over 90%. The task force kept LGS on purpose. It's the key that unlocks LGS specific drug approvals and disability services these children depend on. The EEG is diagnostic, and it's why you need a sleep study. 2 mandatory patterns: generalized slow spike wave under 2.5 Hz when awake, panel A, and paroxysmal generalized fast activity in sleep, panel B. Panel C is a tonic seizure with that recruiting fast rhythm. And a teaching point: after age 16, the classic slow spike wave often fades, so a history of the pattern still counts. Now the SWAS spectrum, spike and wave activation in sleep. This replaces the old CSWS, ESES and pseudolanos labels. The mandatory combination is regression, cognitive, language, behavioral or motor, that is temporarily tied to the EEG pattern. Slow 1.5 to 2 Hz spike wave markedly activated in NREM sleep. If the child had normal development before, it's EESWAS. If there was a pre-existing disorder, DEE-SWAS and Landau-Kleffner syndrome is the specific EE-SWAS subtype where the regression hits language with acquired auditory agnosia. That eponym is retained. Remember, SeLEAS and SeLEAS can evolve into this. And this is the syndrome sleep will reveal that wakefulness hides. Panel A, awake, nearly normal. Panel B, NREM, sleep, near continuous generalized spike wave. If you only record awake, you miss it. You may even need an overnight study to reach slow wave sleep, and time matters. If the SWAS pattern persists beyond 2 years, cognitive outcomes are worse. So early diagnosis is everything. 2 more, both dramatic. Fires, febrile infection related epilepsy syndrome. A previously normal school-aged child, mean age 8, has a febrile infection, and then 24 hours or 2 weeks later an explosive onset of super-refractory status epilepticus. The acute phase runs 1 to 12 weeks with a huge seizure burden and about 10% mortality. Survivors are often left with drug-resistant epilepsy and cognitive impairment. The EEG can show an extreme delta brush. The CSF is typically normal. This is non-antibody mediated neuroinflammation, not an infection you will culture. And HHE hemiconversion, hemiplegia, epilepsy. 2 mandatory stages, acute, a febrile hemiclonus status epilepticus, followed by immediate permanent hemiparesis. Then, usually within 3 years, drug-resistant focal seizures appear. That's the chronic stage. Acute MRI shows a swollen T2 bright hemisphere that later atrophies. The good news is that aggressive early treatment of prolonged status has made HHE increasingly rare. And for the drug-resistant seizures that follow, hemispherotomy can help. Let's put all 11 on one screen. Color coded by family: teal for self-limited focal, purple for genetic generalized, red for encephalopathies, age mandatory seizure, prognosis. Screenshot this one, it's your quick reference. 4 pearls to carry into clinic. 1. Syndromes evolve. SeLEAS into SeLEAS, SeLEAS into EE-SWAS, infantile spasms into LGS. Re-examine the picture over time. 2. Regression is a red flag. New language or cognitive regression plus sleep activated spike wave means SWAS unless proven otherwise. Get the sleep EEG. 3. Test when it changes management. GRIN2A in the epilepsy aphasia spectrum and GLUT1 in the EMATS because GLUT1 responds to the ketogenic diet. 4. Mind the drug traps. Sodium channel agents can worsen many generalized epilepsies, and slow frequency photic testing flags CLN2. A syndrome is mandatory: seizures plus EEG plus an age window plus a prognosis. Never one feature alone. 3 families: benign and idiopathic are gone. Sleep EEG for LGS and SWAS, MRI for COVE, pole, fires, HHE, and naming the syndrome guides the tests, the drugs, the counseling, and access to precision therapy. That's the childhood onset map. Go back to our little boy from the opening. The nighttime facial twitching, drooling, aware, normal by morning. You now know that SeLEAS, and you can reassure that family with real confidence. If this helped you organize these syndromes, subscribe to Nurture and Neurology and tell me more in the comments which syndrome you'd like a deep dive on next. As always, this is educational and doesn't replace individualized clinical judgment. I'm Dr. Aditi Goimawalakar. Thanks for watching.